Welcome to today's Research and Care webinar regarding Duchenne muscular dystrophy and Becker muscular dystrophy carrier statuses. We are so glad to have you join us. My name is Tess Taylor, and I am a specialist with MDA's community education team. Today's learning event is part of our larger MDA community education program, which focuses on bringing the neuromuscular disease community together around education and resources. Be sure to visit the community education section on mda.org for all of our upcoming and on-demand programs, as well as a full list of educational materials. As usual, we will have a Q&A session at the end of our speaker's presentation today. Simply use the chat feature to type in your questions. Feel free to type your questions and send them in as you think of them, and we will address them after the presentation. Please note that today's webinar is a general discussion, and we will not be able to answer questions that are highly specific to your situation. We encourage you to contact your healthcare provider as they know your situation best, and you can also reach out to the MDA Resource Center for more guidance as well, which we will provide contact information for. I'd also like to mention that if you're joining us live, we will be sharing a lot of great resource links in the chat box, including treatment fact sheets, MDA Quest media articles, and things of the like. So keep an eye out on our chat, and also feel free to introduce yourself. We'd love to know who's joining us today. We are recording today's event and will be posting to the website for on-demand viewing in just a few weeks. Everyone registered for today's session will receive a link to the recording via email when it is ready. MDA would like to thank the generous sponsors of our program today, Edgewise Therapeutics. Their support helps make programs like these possible. MDA's mission is to help children and adults living with neuromuscular disease live longer, stronger, and with more independence. Through targeted programs and innovative initiatives, we address the most pressing needs of our community. The purpose of our program today is to discuss the clinical presentation and potential symptoms of individuals who have DMD or Becker carrier status. We will also review best practices for evaluation and diagnosis and discuss patient-centered strategies for navigating care and engaging in healthcare decisions. We hope that the program today will provide you with some takeaways to support you or your loved one's continued care. And now it is my pleasure to introduce today's presenter, Dr. Elizabeth McNally. Dr. McNally is the director of the Center for Genetic Medicine and professor of medicine, cardiology, and biochemistry and molecular genetics at Northwestern University's Feinberg School of Medicine. She is an internationally recognized leader in cardiovascular genetics with extensive expertise in neuromuscular and genetic disorders. Hi, Dr. McNally. Thank you so much for being here today, and I'll now turn the time over to you.
Great. What happened to my share? There we go. How's that?
Perfect. Thanks so much.
All right, great. And thank you all for joining us on this Friday, and I hope it's a good Friday wherever you are. I'm in Chicago, and it is quite a lovely day, and today we're going to talk about DMD and BMD carriers. Just by way of some disclosures, I'm just showing you some of the companies I've had the privilege of consulting for, as well as my research grant support. I'm a founder of Icacca Therapeutics and a co-founder of Cardigan. And I work at Northwestern in Chicago. So what we're going to do today is we're going to talk about an overview, which is going to encompass talking about diagnosis and clinical evaluation, so genetic diagnosis and clinical evaluation. Then we'll talk about how people present clinically and the variability of symptoms that's associated with DMD carrier status. And then lastly, talking about how to advocate for yourself, which is a really important part of this entire process, which is being your own advocate. So we will start with my favorite cartoon, which is showing you what is known as the dystrophin complex. Dystrophin has the purple arrow pointing towards it, and is a very important protein that is present in heart and in skeletal muscle, and it plays a role in stabilizing the membranes that surround every cell, like muscle cells and heart cells. And it attaches to these proteins known as dystrophin-associated proteins, and it makes a connection from the inside of the cell through the membrane and to the outside of the cell. It is composed of all these different domains, actin binding domain, these repeat regions, and what's called the cysteine rich and C-terminal domain. And if we think of muscle cells as having these very long units called sarcomeres, which are the unit of what makes muscle cells and heart cells contract, then the dystrophin complex sort of sits in register with it, where it plays a very important role, again, in stabilizing the membrane that surrounds cells. And if you don't have dystrophin, these cells break down, and that is what is the fundamental problem that can lead to skeletal muscle dysfunction and cardiac muscle dysfunction. So we know dystrophin is one of the very, very largest proteins out there, as well as a very large gene that makes up the protein. Genes are made up of what's called exons, which specify making the protein that becomes dystrophin. And dystrophin, the gene, which is called the DMD gene, it is called the DMD gene, is made up of 79 different exons that all fit together in a particular way. And many of you probably know from exon skipping things that there are three different ending points for each exon. And so a flat edge has to connect to a flat edge, and a caret edge has to match to a caret edge. And if you're missing some of these exons and the two pieces can't come matched up the same way, that will create a mismatch and cause loss of dysfunction. And we know this is that actin binding domain at the very beginning of the gene. And then we have these other specialized binding domains, and then many of these repeat regions in between. It's interesting because I've spent a lot of years studying this dystrophin complex, and more recently, a very cool technique was done where they did what's called cryo-electron microscopy. And while we've worked with this cartoon that is present here, sorry, I keep jumping around, that is present here on the left-hand side, this new study that actually for the first time shows us the structure of the entire complex showed us some new things that we really didn't know about before. And a key thing that it showed us was that these sarcoglycan genes, which directly attach to dystrophin, are really a fundamental part of this complex and make a very big tower, a very long set of proteins that, again, mediate that attachment between the inside and the outside of the cell. And so it's always interesting when there's new data that makes us think about things in new ways. So let's talk about the genetics, because that's where all of this begins. We know DMD and BMD, which are the disease designations, are what are called X-linked recessive diseases, which means it occurs on the X chromosome. And if you lose the function or partial function of the gene, that is what leads to disease. Now, that's a problem for males because males have an X and a Y chromosome, meaning they have only one X, whereas females have two X chromosomes. And so one of the key things that happens when an X and a Y come together, or an X and an X come together and make an embryo, in any given cell, there's only supposed to be one active X chromosome. And so what happens in the subsequent cells is one of those X's becomes inactive. If you happen to be a carrier of a mutation in the dystrophin gene, and your X inactivation favors the chromosome that carries the mutation in the DMD gene, you can end up with more cells in your body that have a mutation in the dystrophin gene. So the process is called X inactivation, and it's really important for all X-linked diseases and females, two people, with two X chromosomes, who carry this, because it can change how much dystrophin is present in all of your cells. So that's also shown here. So normally, again, you have a paternal is XY, maternal is two X's. That comes together and makes a female, where one of the X's has come from mom and the other X has come from dad. And so that means in all the subsequent cells, you have two X's, and one can be active and one can be inactive. And so it really depends which one of these is the one that carries the dystrophin gene. And that's how fundamentally females really are what we call a mosaic, meaning some cells in the body may be carrying the active while other cells in the body are not carrying the active chromosome. And this is just a picture of what we say when we talk about an inactive X chromosome. It actually clumps up here in the corner of the cells. That's the inactive X chromosome. And that's what, if you ever remember the old days where people used to do bar body testing to look for females, that's how you prove it, because every cell in a female has one inactive chromosome that can be detected as that clumped up bar body in the corner of the nucleus. And so females are, as we always know, much more complex, and meaning that their X chromosomes in different cells, you have different X chromosomes being active, which is really important for an X-linked disease. So that's shown here, where again, imagine you have, again, two X chromosomes, one which is carrying the DMD mutation, the other which is not carrying it. And in subsequent, if your cells contain the active X chromosome that doesn't carry the DMD mutation, and the DMD mutation instead has been relegated off into that inactive X in the bar body, this is going to be a more functional X chromosome. So if more of your heart cells and more of your muscle cells are made up of this X chromosome, in general, you're going to do quite fine. Whereas if you do more of your active X chromosome carries the DMD mutation, then more of your heart and muscle cells will be defective for dystrophin, and you may have more symptoms. And I just want to point out that most of the time when we do genetic testing, we're doing it on blood cells. You know, you give a tube of blood and they do your genetic test on that. Or sometimes you'll do a smear in your cheek or a saliva sample, and that's testing different cells. And that may not be reflective of what's happening in your heart and muscle cells. So while we can test your blood cells or your cheek cells or your saliva, it may or may not reflect exactly what's happening in your muscle and your heart. And that's how sometimes we end up with females who have more symptoms in their muscle or in their heart. So what do we know about carriers? This is a nice paper that came out last year from Elena Pegueraro's group, which looked at a number of carriers of Duchenne muscular dystrophy gene mutations. And what we found was most interesting about this was they just measured serum creatine kinase, or serum CK. We all know CK is one of the measures of if your skeletal muscle cells are breaking down, then CK leaks out of your skeletal muscle and into the bloodstream, and we can measure that. And so this is looking at how high CK levels are and correlating it with symptoms in people. And so here's lower levels of CK correlated with mild symptoms, intermediate levels of CK correlated with intermediate symptoms, and those who reported having more symptoms had higher levels of CK. But what I find most striking is all the people who say they're asymptomatic have this enormously large range of CK, which means to me that there are just some people that don't experience, don't acknowledge, or just don't recognize that they really are having symptoms. And that's always hard because we each get to live in the one body we were given. And we may not recognize that, for example, somebody gets a little more sore after exercise than other people do. And that might be the kind of way that symptoms show up. This is just an example of what the skeletal muscle looks like from a carrier. And you can see here, each one of these individual cells is showing you dystrophin expression. And you see between them, there are areas of cells where there isn't any dystrophin expression. And that's, again, that patchwork phenomenon that happens because of the X inactivation process. So these cells that are showing dystrophin had the good X chromosome making normal dystrophin present, while these other ones where you see there's no dystrophin, they had the mutated X chromosome showing no dystrophin. And so again, it's how skeletal muscle and heart muscle can end up with this patchwork expression of dystrophin. This work actually went and looked at females who were carriers and correlated it with how likely were these individuals to develop cardiomyopathy. So cardiomyopathy is the term we use when the heart muscle is affected by the, in this case, loss of dystrophin. One of the things we can measure is the size of the heart. The heart tends to be larger in size. So this is looking at carriers over this age range, all the way up to the age of 80, starting down here at the age of 20. And most people have a normal size heart. The normal line is here in red. And you see that a relatively small number of these dots, every one of these dots is an individual. So only about 4 of them were above the line saying that their heart was enlarged. Most people have a normal sized heart, but of the few that were elevated to the size of normal or just above, they were mostly older. So this is people who were over the age of 50. Similarly, if we look at reduction in heart function, the vast majority of people have pretty normal function. So again, normal here is above the red line, and a relatively small number, 6 of them, had heart function that was below normal, and most of those were, again, over the age of 50, suggesting that this is a process that overall isn't terribly common across carriers and increases the chances of it increase with age. We can model this better in mice where we can do some tricks to actually make, again, mice that have more of that patchwork expression of dystrophin across their hearts. And then we can mark and show that in the places where there isn't dystrophin, there is more likely to be injury of the heart. And so in this is a section of a heart. Each one of these are sections of a heart, and the red staining marks injury to the heart, and the green staining marks where there is dystrophin. And what you can see is that there is increased injury where there is not dystrophin. So those cells that don't have dystrophin are more likely to break down, and that's because they don't have dystrophin stabilizing the membrane. And I just like this because it's a very nice visual that really shows dystrophin is important. So how do we look at this in humans? We obviously don't take out people's hearts and stain them for things. Instead, we use tricks like cardiac MRI. So this is a magnetic resonance imaging where you have to go in the big machine to get pictures of the heart. The other way we do look at the heart is by echocardiography, which is just ultrasound of the heart. But the MRI actually gives us much more information about the quality of the tissue as well as heart function. Echo is great for heart function, but MRI actually lets us look at the quality of the tissue itself. And we can do something called look for delayed enhancement. It requires an injection of a tracer called gadolinium. And if that gadolinium tracer gets held up in the heart, as exhibited by these sort of white lines that you see here, that indicates scar or that breakdown or inflammation that is present in the heart. And so that's how we look at it. And cardiac MRI is absolutely one of the most sensitive ways we have of looking at the heart right now. And it is my preference to go as first line to actually doing a cardiac MRI. Although I'll tell you that a lot of times, certainly in the United States, we have to do an echo before the insurance companies will approve an MRI. But an MRI is actually a better and more sensitive test. So here's another look at what we know. How well do we know whether muscle involvement correlates with skeletal muscle involvement correlates with heart muscle involvement? And the answer is, just like in Duchenne and Becker patients, there can be a mismatch between how much involvement there is of the skeletal muscle and how much there is of the heart muscle. And we see that here by, again, correlating it with serum creatine kinase leak and fractional shortening, where you see only a very rough correlation that those with the highest CKs also have some bit of lower fractional shortening. But for example, individuals here and here have lower fractional shortening, less heart function, but don't have that elevated of CK. So again, the skeletal muscle and the heart muscle involvement don't always have to be correlated with each other. But what we do know is that levels of dystrophin, as I showed you before, where there's dystrophin, the cells are protected, and where there's not dystrophin, the cells can break down. And so this was a very clever experiment done in mice where they had varying degrees of exon activation. So they basically changed the exon activation in different mice that carried the DMD mutation and correlated with how much dystrophin you needed to have to actually get good protection for the overall function of the heart. And so what happens is the heart function actually gets worse when you don't have any dystrophin, which is the black bar here. But you also can see that you have to watch it over time where that difference becomes magnified. And then you do start to see some difference that's somewhere between 6 and 25 in terms of percent of dystrophin that matters. But we know for the most part that most carriers are going to do pretty well unless they have sort of unfortunate exon activation where they have more of the inactive dystrophin gene present in their heart. So let's translate this a little bit to what we know about Becker muscular dystrophy. In Becker muscular dystrophy, the people with Becker muscular dystrophy, again, by and large, these are males who have only one X chromosome and it has a mutation, but that mutation in the dystrophin gene still makes some amount of dystrophin. And in that case, we also can say, well, if the dystrophin happens to be missing portions here in this very front part of the gene, that correlates with having more likelihood to have cardiomyopathy. So for those who are counting exons, those are like the beginning exons 3 through 10, or even the ones encoding these first repeat regions. Those are more likely to have cardiomyopathy at an earlier age. These are the most common mutations in the area 2. Those are more intermediate in their heart function. And those who have mutations here in what's marked as 3, so just after 2, those tend to fare best from the heart standpoint. And there's a big range in each of these. So this is just a rough general guideline. But this, I would say, is consistent with what I've seen all the years, which is these mutations that really affect the actin binding domain seem to actually have worse heart function over time. So just a little, meaning watch a little more closely if your mutation happens to fall in that range. So genetic testing has changed a lot over the years. I take care of a lot of Duchenne patients and Becker patients who are older. So when I'm taking care of their moms, a lot of times their genetic testing was done 20 or 30 years ago, because the patient that I'm following is now 30 years old, and mom's test was also done 30 years ago. And it's important to recognize that a test that was done 30 years ago may not be correct or may not be precise. And that's because of how much testing has changed over the years. So if you first had your genetic test in the 1990s or early 2000s, sometimes the testing was really just using serum CK, which we know is not reliable, X chromosome markers, which is also not entirely reliable. And then it was really testing from somewhere in the early 2000s to about 2015. Most of the testing was based on doing a PCR across the gene to look for certain deletions, and then sometimes doing direct sequencing. And this was reasonably reliable, certainly more reliable than the testing before that. But then from 2015 on, and this is a very approximate date, most of the testing was done by what we call short read sequencing, which again has an even higher accuracy. And so since the methods have gotten better and more accurate over the years, it's important to look at your test when it was done and make sure that it's accurate, particularly if you had a negative test, because we know there are situations where it may just have been missed. And that's really important to, if you think you're not a carrier, to make sure your test isn't from 35 years ago and that it doesn't need to be repeated. It may need to be repeated. The other piece of this is that to validate your testing, if you do want to repeat it, your son may need to repeat his testing first. And that's just so that they have a good positive to know what they're looking for. It's always more tricky to do the females in testing because there's 2 X chromosomes. So there's one in the background that might, change it, how they read the result. So why do we need to know whether the test was correct? This is mainly if somebody was told they were not a carrier. We want to really be sure that that's correct, that you really are not a carrier of the gene. Approximately a third of the DMD gene mutations, and that DMD, when it's written in those italics like that, just means the gene. The DMD gene is what we call it. It's not called the BMD gene. It's called the DMD gene. That is the gene's name. So, and that can mean both Becker and Duchenne. And that's why a lot of times you see it called the DMD, right? So 1/3 are new mutations, meaning that it wasn't detected in mom. 1/3 is a pretty high number compared to most other genes. And it could, in a few cases, represent just missed positives, so what we call a false negative. A mosaicism is when some of your cells carry a mutation, but other cells do not. And if they happen to test your blood cells or your saliva cells and they just didn't get a good representative sample, sometimes it can just be missed. And as we talked about, exon activation is not 50-50 across all your cells. And if your blood is different from your heart and muscle, again, that can be a reason why it's missed. And so both mosaicism and skewed exon activation can cause false negatives. And it's just another reason to think about repeating your test if your test was negative. So again, find your testing, look at where and when it was done, maybe ask your doctor whether it's worth repeating that. What do we know about carriers in terms of what we can expect? A wide range of answers is the answer to that. For cardiac involvement in DMD carriers, and here I'm just referring to the gene DMD, it's anywhere from 8.5 to 12%. And this was a study where they went back and looked at 7 articles from 1,000 articles that they found. So, that's it really depends on how you look at whether somebody has involvement of their heart. So, for example, if you actually do MRIs on people, this bullet point number 3, up to 50%, 56% of individuals will look like they have some form of myocardial damage across carriers. And some people will label that as cardiomyopathy, even though the individual may not have any symptoms at all. And so that's why it's very important to, like, when we say how likely is it that the heart's involved, it really depends on how we're answering that. Do we mean involved in that people are having symptoms, or do we mean involved in that we can actually see something on the MRI? If we're just going by the most sensitive measure, which is MRI, it can be as high as 50%. But if we're going based on having really reduced function and even symptoms, that number is probably under 5%. So most people are not going to have symptoms in their heart from being a DMD carrier. Symptoms in the muscle are, again, very, very wide ranging. Some people may actually have real weakness. Some people may get weakness to the degree that they really can't walk long distances or need to use, wheeled support. Other people may just have mild myalgias, which is aching of the muscle, or cramps, or just exercise intolerance that they've had their whole lives and just don't really see it as a big problem, and they still go about living their lives. So symptoms of muscle involvement are really variable, largely because it depends on how people report them. So let's talk about how to manage the heart. We had an update of heart guidelines about managing the heart in neuromuscular disorders. This was actually from 2022. We also had another update on heart failure recommendations. Heart failure is the symptom of when somebody actually, their heart isn't providing enough for what they needed to do, and so they'll have shortness of breath and fatigue and things like that. We also know there can be electrical problems. And so these are big processes when these guidelines come out. They sometimes take years to come out, and many people involved in the process of making the recommendations. And sometimes we don't have a lot of great data in the literature, and we just make best recommendations. So the heart failure guidelines, which also came out in the same 2022, really identify what we call the 4 pillars of treating a heart that has decreased function. And those are 4 major medication classes, which are what are called ARNIs, or ACE inhibitors, or ARBs, beta blockers, mineralocorticoid antagonism, and SGLT2I. Those are really the 4 most important parts. And if you're seeing a cardiologist, you do have reduced function. The goal is to get people on all 4 of these medications if they can tolerate it. And then we have lots of other management for irregular heart rhythms and things along those lines. So we call this in cardiology guideline-directed therapy, and it's for individuals with heart failure with reduced ejection fraction, which is called HFrEF, but can also be applied to people with cardiomyopathy. And again, the mainstay treatments are beta-adrenergic blockers, angiotensin receptor blockers, which are sometimes ARNIs, or ACE inhibitors, or ARBs. Those are all considered in the same category. Mineralocorticoid receptor, and SGLT2I, which is also medicine to treat diabetes. And if somebody has swelling or fluid overload, we use water pills or diuretics. And the hard part about treating many genetic forms of cardiomyopathy in carriers, as well as in Duchenne and Becker patients, is that a lot of people don't have very high blood pressure. And almost all of these medicines lower blood pressure. So we have to be very careful with our medications to not make people's blood pressure too low. This is a landmark study for those of us in cardiology, that using a medicine called sacubitril valsartan really, really has a huge impact in improving outcomes in people who have reduced function on their heart. It reduces death, it reduces hospitalization, reduces death of all causes. So again, very well tolerated, and this was compared against enalapril, which was standard of care at the time. So this is the best medicine we have for treating the heart. It is a generic medicine now, and the long name is sacubitril valsartan. The previous trade name was Entresto. The downside of this medicine is that it really lowers blood pressure quite a lot, and so sometimes we can only get people on pretty small doses. We do have some studies in Duchenne and Becker patients looking at ACE inhibitors, and again, looking at fibrosis in using magnetic resonance imaging in the heart. And we can actually show that the fibrosis in the heart changes over time with treatment. What I notice with most of my patients and my carrier moms that I take care of is very often, if we do catch heart function down and we start these medicines, we can often get heart function to improve. Now, that is still a heart that doesn't have tremendously great reserve, but in baseline everyday life, it is more than sufficient for what is needed. This is probably our most recent, newest medicine that we use, and it's now been around for quite a few years, which is to use SGLT2 inhibitors. Ththese are medications like Jardiance or Farxiga. They were initially came out because they were for diabetes, but after a whole bunch of people were on this for quite a few years, it started to become clear that it was really making heart failure outcomes much, much better. So then a series of trials were done to show that you didn't need to have diabetes, and being on these medicines also greatly improved outcomes. And so this is now part of our mainstay of managing patients as well. Let's talk about imaging a little bit. You've heard me mention a couple of times I recommend cardiac MRI. I like it because we do that injection of gadolinium and we really can see the quality of the tissue. Where we've looked at this in Duchenne patients, those who have more scar, we know that it predicts that they're more likely to drop their heart function over time. So if we do an MRI, either on a carrier or on a DMD, BMD person, and we don't see any evidence of scar, so there's no LGE present, that's actually an incredibly good sign. And it means that whatever is happening in the heart is not so terribly active at that point in time. Once I start to see that there's any scar present on the heart, that's usually where we talk about starting at least some of the medications for treating the heart. If we see a lot of scar that goes all the way across the wall of the heart, we know that that also predicts worse outcomes. And so again, if we see those things on MRI, we're much more likely to start treating sooner. And then we know in our DMD cohort, less commonly in our BMD cohort, that we use glucocorticoid steroids. So that's most commonly prednisone or deflazacort. A smaller number of individuals are on vamorolone. That's mostly used in the younger boys at this point in time. Just we don't have a lot of data in the older ones. But what's interesting is that using steroids is associated with prolonging heart function in a better state for a longer period of time. And so, again, we don't have really a lot of great information in Becker patients. I know some Becker patients are treated with steroids, and I know some real manifesting carriers from a skeletal muscle standpoint may also be offered steroids for treatment, usually at some dosing that may not be every day, but it might be, say, 2 days a week, to avoid some of the side effects that can come with being on steroids. So I just wanted to tell you about one case. This is a 37-year-old person with DMD that I've followed for a number of years, and his mom I follow as well. And he has a typical exon 45 deletion. He stopped ambulating around the age of 13, family history of a maternal uncle who died at 28 from DMD. So that's his mutation. It's an out-of-frame mutation. And he's kind of an intermediate phenotype between, sort of on the good side of being Duchenne, I would say. His baseline heart function was 45%. Normal is 55%, so down, but not terribly far down. He did have some non-sustained ventricular tachycardia on monitor, did not have an internal cardiac defibrillator, and he was on good medications, those 4 pillars that I talked about, and weekly prednisone, and used BiPAP for his support. And this is just showing you a tracing that he does have some non-sustained VT. So he was doing well. It was the end of summer, beginning of September, and he developed some mild cold symptoms and recovered after about 3 days, but was home one evening. And his mom, of course, like most households, someone gets a cold, mom gets the cold in the house as well. She recovered, but she also felt kind of tired afterwards. She is, after all, a full-time caregiver, so totally understanding. But about a week after the DMD person had resolution of feeling better from the cold, but he developed some very serious chest pain, chest pressure in his heart that felt like an elephant sitting on his chest. Tried to go to sleep, but couldn't really sleep very well, and still had it in the morning, so decided to go to the emergency room. And when he was in the emergency room, this EKG showed what we call here, these red arrows are pointing out what's called ST elevation, which is a sign of acute injury in the heart. And as cardiologists, if we see acute injury, this is called a myocardial infarction or a heart attack, but can come from a number of sources. But when this is seen, this will often trigger somebody going immediately for angiography to look at the heart blood vessels and to see whether there's any blockages in the blood vessels. We really don't expect blockages in blood vessels in people who are 37 because that's like too young to normally get that problem. But that's what you do when you see this. The other thing that was very concerning was there was a huge elevation of this blood marker called troponin, which is a marker of injury. Just like we use CK for the skeletal muscle, troponin is the marker for the heart. And his troponin was sky high in the many, many thousands. And they looked at his heart arteries, took him to the cath lab, looked at the heart arteries. They looked great. There was no problem there. And so this is the conclusion that there is just an acute injury problem happening in the heart itself. And we call that myocarditis. And so what happened is it got really bad on day one, then it kind of went up at the end of day one, up into the 27,000, 29,000, 28,000, and then started to go down by the end of day two, which was good news. It suggested it was resolving, but still very, very high. Myocarditis just means something happens that suddenly in the heart, there becomes a lot of inflammation, injury. This can be associated with arrhythmias and dysfunction. And so we have to take it really seriously when it happens because there can be irregular heart rhythms. Luckily for this patient, it was just supportive care, get his medications back on, make sure everything was going okay. And he got better and he did recover. There are many cases of myocarditis episodes being described in Duchenne and Becker patients. And these are individuals who can just show up, suddenly have a chest pain. They check in the emergency room. There's troponin leaking. There might be irregular heart rhythms. They look at the heart arteries. Everything looks okay. And usually we can just support people and get them through. And there can be some decline of the heart function during the time, but hopefully it usually recovers afterwards. What was interesting in this case was he turned out to be positive for SARS-CoV-2, which was, as we know, causes COVID. And there have been lots of descriptions of getting myocarditis from SARS-CoV-2, but honestly, this can happen after lots of different kinds of viral infections. But what was quite interesting in this case is I mentioned that mom got the cold as well. And just kind of following along a few days, everything after her son, she also developed like a round of palpitations and really bad fatigue and even like a little bit of chest heaviness. And by the time I saw her, it had probably all resolved. But I think she ended up having a very, very mild version of what he had. And it was probably just related to, again, getting a viral infection and just carried over. So it's to point out that carriers can have this usually mildly, but can leak troponin from time to time. And that's really important because sometimes doctors like to over-respond to troponin being elevated, and it is normal to have elevations of troponin if you're a carrier. This was that patient, not the mom, but the son. His heart function went down a little bit, but it did recover. By 6 months, it had recovered back to where it had been at baseline. So let's talk about these cardiac biomarkers in neuromuscular disease. It is very common to have elevation of these biomarkers. I'm broadly using the word troponin. You can measure troponin T or you can measure troponin I. Different hospitals use different ones, and they are markers of heart injury. They are also high sensitivity tests like this. And when I check my carrier moms, I would say, at least 20% of the time, just I'll catch a little elevation of troponin. So it can just naturally happen in people who are carriers, and it's just something to be aware of. And I like to document it at baseline so that people don't overreact to that can be present. In other words, we know that it's there. This other marker is called NT-proBNP. This is a marker of heart function. And there's the high sensitivity one is this one is called NT-pro. There's also one called just BNP. This I also like to check on a regular basis because I do catch it elevated a fair amount of the time. Not usually terribly elevated, but it's a great marker to know how people are doing from the heart failure standpoint. And the NT-proBNP is a very good sensitive marker to use in people with neuromuscular disease and also who are carriers. And then we talked about CK, which is great for skeletal muscle. CKMB is supposed to be specific for the heart, but it isn't in Duchenne patients or neuromuscular disease in general. It can also come from skeletal muscle. And then there's some others. But the point is troponin is the one for injury and NT-proBNP is for heart function. Those are the important ones. We do know that troponin leaks happen a lot in DMD patients. It's quite frankly made it complicated for a lot of the different clinical trials going on because it can be up in the background and then it can be up in response to a treatment. And so it can be very hard to follow, but it's just something to be very aware of that it can be elevated. We did a meeting a bunch of years ago to really document that, in fact, this intermittent elevation of troponin is common in DMD. It's also can be seen in carrier females. If your doctor looks for it, it's going to be seen. You shouldn't overreact to it in any way. It's just important to know that that can happen, and so to pay attention to it. So imaging and biomarkers, those are the main ways we like to follow people. We can use echo, we can use MRI. We do know that if we measure left ventricular ejection fraction, LGE, which is that inflammation pattern that's on MRI, if we measure strain on the heart and NT-proBNP, we know that in our Duchenne patients, that correlates with having a worse heart and worse outcomes. And when we see those things, it makes us think about whether we should start treating earlier, again, with these medications, many of which are very well tolerated. And in our practice, that's usually conversation that we have, the same conversation that I will have with carrier moms. You know, if you have a little bit of elevated blood pressure, we do see a little bit of scarring on the heart. You know, we'll pick one of these medications to manage blood pressure because we know they do double duty and they have extra protection for the heart. So it's just meant to tailor the management options that are out there. We can see fibrosis on the heart in the setting of having a normal heart function. And so that's where, again, we want to recognize that represents the earliest phase of disease and an opportunity to potentially start treatments earlier. And the treatments are, again, those medications are very well tolerated, very benign, very good for anybody who has any high blood pressure and can offer protection for the heart. So how do we manage your heart because you are a carrier? As I said earlier, you want to confirm your genetics. If you're sitting on a negative test, then think if the test is 30 years old, you might want to think about repeating it. I recommend carriers have a baseline MRI, and then every 5 years after that. If the MRI was normal, then it's every 5 years. And if you can't get an MRI, echoes are okay, but MRIs just have much more sensitivity. I recommend a baseline EKG, and that's probably about every 5 years to look at that. I like to do baseline biomarkers. We talked about the NT-proBNP, and cardiac troponin. If you're experiencing palpitations, skip beats, extra beats, lightheaded episodes, fainting, I love to do extended Holter monitors. These are skin patch monitors that you can wear for 14 days or even up to 30 days in some cases. And it just gives us a fantastic view of what your heart rhythm looks like. Lots of people are wearing smartwatches these days. They can detect things like atrial fibrillation, but the extended Holter monitors, the skin patch monitors pick up a whole lot more. They're really a superior test, but the smartwatches can be helpful for some things as well. If you develop chest pain or chest pressure and check a troponin, it might be elevated and it may not, it probably doesn't indicate coronary disease. And so that's why you just have to have knowledgeable physicians that are aware of this. And that's why it's so useful to have a good baseline documentation. Don't forget about general health recommendations, which is manage your blood pressure. If you have high blood pressure, beta blocker or ACE inhibitor are maybe good choices because they do double duty and protect the heart. Know your cholesterol. We have new cholesterol guidelines that came out this year. So you should know your LDL, which is the bad cholesterol. And the new one that is recommended for everybody to have is what's called LP little a. You're supposed to get that checked now once in your life. And if you do have elevated LDL cholesterol, we use statins to treat that. Some people say you shouldn't ever take statin if you have muscle disease. You can take a statin if you have muscle disease. If your muscle disease gets worse on a statin, then you should go off the statin. But that's also something to be aware of. Coronary calcium scans. These are now being used a lot more. This is a quick, usually pay out of pocket test to look if you have buildup of calcium on your heart arteries. Useful after about the ages of 45 to 50. Again, if you have a negative test, no calcium on your heart arteries, that puts you in a really good group. If you have a buildup of calcium on your heart arteries, sometimes it's worth thinking about being on a statin. Common sense things, don't smoke. Manage your diabetes, exercise, diet, and medications if you need to manage your diabetes. And then the last is how to manage your muscles if you're a carrier. Exercise is healthy, but do be sensible. If you're doing certain activities and they're causing you a lot of muscle pain, you're probably having muscle breakdown, and that's probably too much exercise. So use pain as your guide, and don't do things that hurt. If you develop instances of very dark urine, red, dark brown urine, this means you've had muscle breakdown and you should talk to your doctor about this. This means you may be more of a manifesting carrier than what you recognize. GLP, everybody's interested in GLP medications these days. These are medications to help you lose weight. And there's a lot of information these days about them causing some muscle wasting. We're actually using them a lot. Cardiologists end up prescribing them a lot. And I am even prescribing them in my Duchenne, Becker, and carrier patients. But you need to stay active to avoid losing muscle mass. The loss of muscle mass is much more a problem for older people and for people, again, who we have to watch it in muscle wasting situations. But so far, I have not seen specific problems in my Duchenne, Becker, or carrier patients. Be cautious in heavy lifting. I say this because as carrier moms, I know you sometimes have to you are the primary caregiver and you have to do a lot of lifting. So just be sensible about that. Watch your back, watch your, get Hoyer lifts, do the things that you can. You want to protect your bone and muscle health as best you can. And you do want to pay attention to your bone health and watch for osteoporosis and things like that. But those are just common sense things beyond that. So I think that's my last slide. And I'm happy to open up for questions.
Thank you so much, Dr. McNally. That was a wonderful presentation. We do have some questions for you. We had some in the chat as well as some questions that came in at registration. So for those of you who are live with us today, if you do have any questions, especially general questions, please be sure to put those into the chat for us and we'll discuss them. A few questions that came in the chat, they're a little... they're related kind of on the side. So if you don't have direct answers, that's totally fine. But I still thought I'd ask them anyway. So our first one is, how can someone end up with multiple dystrophies, such as having Becker and FSHD combined? And can this make their symptoms worse?
So that would be what I would call very bad luck if you ended up with two different genetic diseases. And I've been doing genetics a long time. And, for somebody like me that's been taking care of lots of genetic patients, I will tell you, I do see it. It's very rare, but I definitely see instances where there's more than one mutation in a family. I mean, I follow one family that has both myotonic type 1 and type 2 in the same family. Definitely these things can happen. It's very unfortunate because having two problems is obviously worse than having one. And that's just, highly complex to manage. You want to, again, follow the same rules. If there are any of the forms of muscular dystrophy that can affect the heart, then obviously you need to be seeing a cardiologist. If they're only ones that affect the muscle, then your neurologist can really help you navigate through that. I'm going to also guess that if you have like two different insults that can affect your skeletal muscle, the other part, which I didn't talk about much today, is making sure you have a good pulmonary doctor that helps you with breathing, because your breathing muscles can be affected. And so you want to make sure you've got a really good pulmonologist who manages you. You might need nocturnal support for breathing, but it is entirely possible. The world is a big place. There are billions of people on this planet, and you can just do the calculation that across billions of people, yes, sometimes we will see people with two different genetic diseases in the same family, or sometimes even in the same person.
Thank you. Thanks for sharing that. That's helpful. So this person also asked, can you get muscular dystrophy de novo? They were told that their muscular dystrophy was de novo and no one else in their family has it.
So that's, again, probably most common is to see that in Duchenne and Becker. And that's because of, again, the nature of the DMD gene is a big, huge, long gene. It's over 2 million bases in length, and it has a lot of repeating structures. So just when it makes eggs and sperm, it just naturally makes mutations in it more than other genes because of the size and complexity of the gene. But we also know that there's forms of muscular dystrophy that, again, it's just bad luck. It can just take one little tiny change in the wrong gene, and that can be a de novo presentation. I've seen that across almost every genetic disease. We know that that can happen. Muscular dystrophies are no exception. One of the observations I've had over many years is often when I see a brand new de novo mutation in an individual, it's often, especially for skeletal muscle, more symptomatic in that person. And then if they live long enough and they have kids and their kids have kids, you sometimes see it not quite as severe in the next generation, which is an interesting observation. But that's just a little, pearl I've noticed over the years. I've seen that with Lammin. I've seen that with Marfan patients, which are not muscular dystrophy patients, but I definitely see that with Marfan. The way you determine something is de novo. It's important to actually do it the right way, which is to make sure both parents have been genetically tested and proven, one, to be the parents, and two, to not carry the gene change. And so for kids these days who show up with muscle disease, well, they'll usually first just start with the Duchenne and Becker gene test because that's easiest. But what they do is what's called a trio exome, where they will do both parents' genes and the child's genes, and they will look for what is new in the child. And that's now become a routine genetic test for kids. And that's how we pick up a lot of de novo mutations that cause lots of different diseases, not just neuromuscular. So very commonly done in pediatrics to do it that way.
Great, thank you. So someone else in the chat asked, in general, if you have normal heart function confirmed on an MRI, should manifesting carriers be on preventive heart medication? Is that necessary?
That's a great question. I view that as one where it's a conversation that we have. And I kind of look for, is there any other reason to put this person on medication? So, for example, if blood pressure is trending a little high in that individual, I will not just let that blood pressure be. I've got another reason to use those medicines. And again, I'd reach to a beta blocker or ACE or ARB just to treat blood pressure, knowing that it's also protecting the heart. But I will say there are some people that they'll look at the heart and they'll say, everything looks great. There's no evidence of scar. There's no evidence of arrhythmias. Let's just leave this alone. Blood pressure is perfect. There's no reason to treat at this point in time. And that's often true when a carrier is 20 years old or 25 years old. It just, the equation changes as the person gets in their 40s and in their 50s and in their 60s, in part because blood pressure tends to go up with age. And so that's where, again, we end up in those conversations. But for a lot of people who are in their 20s and 30s, the heart looks great, blood pressure's great. There's probably maybe no reason to treat at that point in time. It's not wrong to be on preventative medications if it's not causing any symptoms or problems to be on it. But that's definitely a conversation to have with the doctor. That's what we call shared decision making, where we get to make the decision all together. So
Yeah, absolutely. And it sounds like a continued conversation as we age as well.
absolutely,
Um,
absolutely.
so thank you. So another person asked, what kind of care should be done for young teen carriers?
Good question. As I just said, when you're younger, mostly likely to be okay. Probably the most important thing for, let's say you feel totally fine, muscles feel great, you participate in sports, no problems there, heart looks great, MRI looks perfect, nothing's happening. Most important thing for a carrier is to just be sensible, don't do things that hurt your muscles. You don't need exercise restriction, just use the guidance of it, it doesn't hurt the muscles. And then it's more about when you get to be of reproductive age. So get into your 20s and maybe you're starting to do family planning, to remember you're at risk for having a child with Duchenne. And so always remember, any thought about planning pregnancies, do it in conjunction with your doctor, with your genetic counselor and your genetic team, because pre-implantation genetic diagnosis is really important. That's where you take the steps to make sure not to pass on that DMD gene to a male and have it end up with a child. So it is completely doable. Insurance pays for it. We do it all the time with our patients. And it's just to make sure that as you get to that stage, when you're ready to think about planning to have your own family, that you've talked with your doctor and your genetics team, and that you're taking the steps so that you don't have to pass that on to the next generation. It's within your control to do that. It's common part of medical practice right now. And so to just be thoughtful about that. So that's hopefully not for your teenage years, but for after that.
Absolutely. Well, I think that actually prompts a couple of the questions we had at registration as well. One of them being, if I'm a carrier, should my daughters also be tested? And it sounds like that
Yes.
absolutely we should
Yes.
to ensure that.
Yes, and those tests are very straightforward. And again, sometimes they want to start with a male in the family that they know what the positive is. And then that way, once they know what they're looking for, then the test on any of the female relatives is very straightforward to do and can be done off saliva, buccal smear, or blood.
Perfect. Thank you so much. And another question we had at registration that's a little related. As a carrier female, do I have a higher risk of getting heart failure during pregnancy?
That's a good one. I get asked that one all the time. And part of this, I always like to tell my carrier moms, part of this is we have to manage the OBGYN doctors. That's actually who we're managing. They want you to go through a pregnancy and do great. And that when you come in for that delivery, that they can do all their focus on just the delivery and making sure everything goes smoothly. And so our job as the cardiologist is to make sure that that happens. So my practice when I'm taking care of a carrier mom is usually to do an echo midpoint in the pregnancy. I usually will ask mom to also wear a heart monitor for like a week just to make sure everything looks great so that we don't have any surprises when we show up and we're ready for delivery and that we can just focus on the happy delivery and wonderful birth and not have to worry about the heart. Most carrier moms are going to do just fine. I have one actually who I just saw recently in clinic. I did have one carrier mom whose heart function was down a little bit. I took her through two successful pregnancies. Her kids are now 10 and 8 and doing great. And she did PGD and everything's really good. So it is totally possible, even if you do have some cardiomyopathy, you don't want to be on ACE inhibitors or ARBs if you're pregnant. So if you're planning pregnancy and you're on those medicines, you want to come off those medicines because those are bad for a developing fetus. Beta blockers are usually okay to stay on if you have to, but again, you want to do that in conjunction with your cardiologist because there can be some complications at the time when the baby's first born because some of those drugs can cross over to the baby. So even if you have heart involvement, we can get you through pregnancies. You just want to make sure your team is all engaged and knows what it's about. But for most carrier moms, the vast majority, they are not going to have heart involvement. They're going to do great with pregnancy. But let's do an echo, let's do the biomarkers, let's do the monitor and make sure everything's in ship shape so that we can have a good and successful delivery, which is what we do. I will say this comes up a lot now because a lot of people are doing prenatal genetic testing and may not know they have a family history of DMD, BMD, but they'll do a test, one of these prenatal screens, and it will test that BMD is on those panels. And so we get referred now a fair number of carrier moms who didn't know they were a carrier because they did this proactive genetic testing. And again, we manage them through, they do great.
Wonderful, great, thank you. That's very hopeful information, I think, to get. The next question we had was, if testing was done on my siblings in 2015, should they be retaken? They're all healthy.
Yeah, 2015 is probably a decent test, but if you have any, because that's like right at that transition point when was starting to be using next gen sequencing and so more precise. That probably, if you have any questions about that, I would contact a genetic counselor or a geneticist to review that testing and just ask that question. Now we're getting into the specifics of like, what was the exact mutation? How good was it if it was a PCR test versus if it was sequencing? So that might be a good reason to meet with a genetic counselor to just review that.
Great, thank you. So another question that came in was, should carriers go to a cardiologist for their cardiac care, or is there a different specialist that they can go to?
For
Like
the
who
cardiac,
specializes more so? Sorry.
yeah, well, in general, yeah, a general cardiologist, it is a rare disease, and general cardiologists don't do a lot of rare disease. So one thing to do is if you have a son who's seeing a neurologist and obviously plugged into a neuromuscular team, ask them if they have cardiologists that they work with, because that'll be cardiologists who are knowledgeable. So that's to get a recommendation. The other, if you can't do that, look for a cardiologist that does heart failure as a specialty. So that's a specialty within cardiology. It's called advanced heart failure transplant, which sounds scary and terrible, but they are also the people that deal with cardiomyopathies and sometimes people that just have a gene change and they're doing fine and they're just getting monitored from time to time, which is what we do with that. So
Great, thank you. We do have just a few more questions. I know it's two though, so if we need to let you go, that's totally fine. Or if you have a moment to answer just a few more questions.
No, sure. I'm happy to do a couple more.
Thank you so much. So one person asked, as a person in their mid 40s who just found out that about the possibility that carriers could be symptomatic, where should they go to find resources or support or help to manage their care? As again, as someone who's in their mid 50s and didn't really know until recently that they had that carriers could be symptomatic or that they could need extra care.
Yeah, so if it's care for like you're worried that the skeletal muscles again are weak or causing problems, that would be a neuromuscular specialist. And MDA has a wide range of resources to find a MDA care center near you, hopefully. If you're concerned about cardiac care, that's what we just talked about, which is hopefully the MDA center or the neurologist has cardiologists they work with. Alternatively, look for a specialist who does heart failure as a specialist, just because they do cardiomyopathies.
Great, thank you so much. And I will also echo that you should reach out to the MDA Resource Center. We have so many resources available to you to help you get on your journey for support. So I will say that as well. Well, one last question for you, and then I think we'll wrap up. Are there any opportunities to be a study participant as a carrier that you know of?
Well, I do know the folks in was that in Cincinnati or Ohio State? They did a big carrier study a few years back, but I think they fully enrolled that to just try to gather enough. I don't know right now, but I always do refer people to clinicaltrials.gov, which is a website, and you can type in, whatever the condition is you're interested in, and it will pop up any active clinical trials. And you can also search by zip code on that, and it'll tell you about clinical trials. But sometimes even trials that are just what we call natural history studies to try to learn more about what carriers can manifest. There are also natural history studies registered in clinicaltrials.gov. So
Great, thank you so much. And I'm so sorry, we had one last question come in, and I think it's a nice way to wrap this up. Why do doctors go back and forth between Becker and Duchenne carrier? We had this question at registration a little bit as well, but it seems like sometimes there can be some
yeah,
confusion.
well, part of that is because the definition of those terms has been changing under our noses. So let's just talk about males first. We used to say Duchenne was, if you stopped walking before the age of 12, you were Duchenne. And if you kept walking longer than that, you were Becker. So it was simply based on how long a person walked. And then along came steroids, and steroids started prolonging the time, and people would walk for 2 or 3 years longer. And so then we started to have what was called intermediate. It was intermediate between Duchenne and Becker. And then some people would say you had to walk until age 20. And then some people would say it had to do with what your gene change was. And so the whole definitions between Duchenne and Becker started getting very mixed up. And so a lot of people will look at a carrier, a female, and say, well, you're not in a wheelchair and you're walking past the age of 12. And so therefore, if you're a manifesting carrier, we're just going to call it Becker because it's most similar to what we see. So it's mostly just about terminology. And manifesting carrier versus Becker is kind of like the same thing. They may be saying it also based on some people like to be very stuck on the precise genetic mutation of whether it's an in frame or out of frame mutation. Some people will say if it's an in frame, that is Becker. Some people will say if it's out of frame, that is Duchenne. So it has to do with what people are using as a definition. I personally just use the term dystrophinopathy because I think, again, the conditions are changing under our noses with treatments like steroids, with treatments like gene therapy for our Duchenne patients. We are turning Duchenne into Becker. We are making Duchenne a milder disease with all these new things that are happening. And hopefully, eventually we change it into being not disease at all, but we're not there yet. And so I wouldn't get too worried about whether it's Becker or Duchenne. I just like dystrophinopathy because it's all encompassing and it respects the fact that our treatments are having some progress. We have a lot more progress to make, but we are seeing some progress.
That's great to know. Yeah, dystrophinopathy. have to spread that far and wide. I think that would be helpful. Well, thank you so much, Dr. McNally, for answering those questions. I think this was a great discussion, and your presentation was so supportive. So thank you again for sharing your time and for staying late to answer those questions. We really appreciate you and your support of MDA and the community.
Great. Thank you. Bye-bye.
Thanks. And if everyone just wants to hang on for a moment, I just have a few more resources to share with you on this Friday afternoon. And just a reminder, some terrific resources have been shared in the chat today. MDA offers the following resources related to this topic. We always, when we do our webinars live, we love to create this guide that provides a lot of resources that are supportive to whatever we're discussing today. So today we had some discussion about upcoming webinars from MDA in the chat, Duchenne and Becker fact sheets, Quest Media articles that are related to what we're discussing, and so much more. So we hope next time, if you're watching on demand, that you can join us live. And these will also be provided if you weren't able to join us live in our follow-up email. So be on the lookout for that. We hope you will join us for future programs. MDA's community education team offers a variety of learning opportunities like webinars today to print-ready resources and self-guided workshops. Here are a few of the programs we have coming up. We have quite a few programs in the next month or so, so please take a look at our website at mda.org/care/community-ed. And I know that's a mouthful, so please also feel free to scan the QR code up in the corner there, and it will take you directly to the site so you can see all of the webinars we have coming up. We'd also like to invite you to our in-person community education events. We're doing 4 this year, 3 still to come: Chicago in September, Dallas in October, and the Bay Area, California in November. So if you are in any of those areas, please feel free to check us out. These Engage events are designed for people living with neuromuscular disease and their caregivers. Our expert-led sessions, guided by clinicians and specialists in the field, offer a mix of disease-specific education and practical daily living insights, ensuring there's something meaningful for everyone. There is no cost to the community to attend our Engage events, and travel stipends may be available if the cost to travel is a barrier to attending. So please take a look, and we encourage you to learn more at mda.org/engage. Again, MDA would like to thank the generous sponsor of today's program, Edgewise Therapeutics. Their support helps make programs like today's possible. We would love to hear from you. What did you like about today's program? What can we do differently in the future? Please fill out the brief survey that will pop up right after the webinar. Your feedback is important to us. And if you have any questions, or looking for support or resources, if you have a question after today, are looking for support on your journey in care, please contact MDA's Resource Center. They are a wealth of knowledge, and they're available all the time. You can find them at 1-833-275-6321 or via email at resourcecenter@mdausa.org. We'd again like to thank Dr. McNally for sharing her time and expertise with us today. This concludes today's webinar. Thank you for joining us on this Friday afternoon, and we look forward to seeing you again soon. Bye.